Hello everyone. I'd like to take this opportunity to extend a very warm welcome to you. Thank you for attending this webinar at the start of our Mental Health Awareness Week. We've had a really exciting day already with some excellent events going on. So welcome. So this webinar, Seen but Not Heard, Children and Young People's Mental Health and Suicidal Behaviours During the Pandemic, will be delivered by Professor Anne John. I'd just like to thank you for attending. And as you know, this webinar is focusing on mental health and suicide behaviours in light, really, of the pandemic and how this has impacted us. I think the pandemic has impacted everybody, but in particular, we have this section of our population that Anne will talk about at length. I'd just like to ask you, before we carry on, that if you do have questions, please do use the Q&A function at the bottom of the screen. So at the end of the webinar, we'll have about 20 minutes for questions. So if you'd like to just pop any questions into that box, and then I'll go through them at the end, and we'll cover as many as we possibly can. So as this is a very sensitive topic, we appreciate it might be quite challenging for some. If you feel the need to step away, go and take a break, make yourself a cuppa or whatever you need to do, then please do feel free. Okay, so I'm going to introduce you to Professor Anne John. So Anne is a professor of public health and psychiatry at Swansea University. She's a consultant in public health medicine, Public Health Wales. She has a research focus on suicide and self-harm prevention and children and young people's mental health. Anne leads the Adolescent Mental Health Data Platform, and she also chairs the National Advisory Group on Suicide and Self-Harm Prevention to Welsh Government. Anne is a trustee of the Mental Health Foundation and a fellow of the Learned Society in Wales. Over the last year, she's been a member of the Technical Advisory Group to Welsh Government as well, and the Independent Scientific Pandemic Insights Groups on Behaviours, which is a subgroup of SAGE. Anne is passionate about the translation of research into policy and practice. I know you'll have a really interesting and insightful and informative webinar with Anne, and so I'm going to hand you over now. Thank you.
Thanks a lot, Liz. I'm just going to share my screen. So has that come up?
Yeah, all good then.
Cool, cool. So today I'm basically going to talk a bit about where we were at prior to the pandemic and how our thinking has changed since the pandemic in relation to young people's mental health and suicidal behaviours. And I know Liz said it, but sometimes I'll be touching on quite difficult topics, so feel free to leave. So before the pandemic, we were in a situation where we knew that about half of all mental health problems are established by the age of 14. So adolescence is such an important age for people's future trajectories. It's when mental health problems develop, and that impacts on their educational attainment, how much they attend school, social development, relationships with people. So one of the things that you often find is that when people have experienced what we call adverse childhood experiences, that will often affect their mental health, and that will often put them on a trajectory where they will experience more. And about 3/4 of all mental health problems were established by the age of 24. So when I talk about children and young people, I'm really talking about people up to about the age of 24. And the reason we extend beyond the traditional 18 years old is because there are real rapid brain changes going on, which means that young people do not think or respond in the same way as older adults. And by older adults, I mean people in their late 20s, 30s. They're much more sensitive to peer pressure. And often they haven't yet learned that in difficult, challenging circumstances, those times pass. Prior to COVID, there was also a long lag time between young people experiencing their first symptoms and receiving help. Now, some of that is about how, there's a lot of stigma associated with mental health problems. So lots of young people don't seek help, they don't talk to anyone. But the other issue is that, we talk about parity of esteem in my world. So it's like that mental health and physical health are treated equally. But for decades, they haven't been. So mental health services, although, there is more investment now than there was before, including services in universities, we're making up. So there was a report that came out a couple of years ago that showed to make up for the lack of funding that into mental health services, we'd need 150,000 new mental health professionals. Now, even with this new focus, that's not going to happen, which means we really have to think about prevention. So there was a lot of talk prior to COVID that we were in the middle of a mental health crisis, and there was pushback on that. So lots of people felt that we were labelling young people, that we were medicalising what were the normal ups and downs. So there was lots of talk about university students. And if you think about that big transition going to university, you're leaving home, you're leaving your friends behind, it's not surprising that students would struggle. And that people, helicopter parents, middle class parents had forgotten what it was like for their children to struggle without it being a diagnosable mental disorder. So then, within schools and universities, we talk about making young people much more aware of mental health issues. We want them to understand their feelings. We want them to understand how to have respectful relationships. And then there's the whole discourse about snowflakes. And so it was, to me, it was a very discordant conversation around mental health in young people. So on the one hand, we were saying, oh, well, you're turning, things that we used to call shyness, you're now diagnosing them with social anxiety, boys playing games is now gaming disorder, you're pathologizing normality. And then on the other hand, when we were trying to make young people more emotionally literate, so we're going to develop a mental health curriculum in schools in Wales, we then called them snowflakes. So I'm looking at the photo up there that I've put up there deliberately. And one of the things is about the media portrayal of all these things. So there was lots of talk of a mental health crisis. Lots of the pictures were like this. It was, young people sitting there with their heads in their hands, looking miserable. And the reality is that a lot of people with mental health issues, or even with diagnosable disorders, do not look like that. Most of the time they look just like you and me. But other times they're angry. And so it's really recognizing that lots of the ways that people are in the world can hide that they have mental health problems. One of the things that, one of the debates we were having at the time was that we'd raised awareness of mental health issues. So there was a survey that showed, compared to 7 years before, people were much better at knowing when they weren't mentally well. But we still hadn't addressed the provision of services. So we were almost getting to a stage where we had got people to the place where they recognised that things weren't right, they wanted to seek help, but we didn't have the capacity to do that, which is another very difficult place. So what about university students? So there was a lot of stuff in the media about the mental health of university students. One of the discussions that was going on in research was, so when I went to university, only about 5% of 18-year-olds went to university. Now it's just over 25%. So I think in 2019, it was about 27% of 18-year-olds went to university. And what that means is that we've widened access. Now, we haven't achieved broadened access, so you still get, 42% of 18-year-olds living in, less deprived communities will go to university compared to much lower percentages of young people on free school meals. But we really have broadened access. And what that means is that more young people could be bringing issues they'd had with their mental health before they got to university. And then we've got lots of young people congregated in one place. Now that's both an opportunity for intervention, that's an opportunity to do something, but it also meant that needs were greater at university. And so those fivefold increases in the number of students reporting problems could be a mixture of those things, combined with, there was lots of discussion about finances and student debt. So debt, financial pressures and unemployment are very strongly associated with mental health issues and suicidal behaviours. Or another explanation was that the rising trends reflected trends that were happening in young people across the board, whether they were in university or not. And there was a good study that was done that was basically a survey, but it chose people very specifically based on stats so that they represented the whole population. And what we found, so that this first graph shows that over time, there very similar proportions of students and non-students had common mental disorders. Now, common mental disorders are like anxiety and depression. However, if you look at males, that's the top graph, that was higher in young people who weren't in university. But for females, it was students, female students, where common mental disorders were higher. Now, what this sort of says to us is that basically we know that there has been an increase in common mental disorders, anxiety and depression between those. So these three surveys in 2000, 2007 and 2014 asked the same questions, so they're comparable. So we've seen an increase, particularly in older adolescent females, in common mental disorders over approximately the last decade. And that increase is also seen in self-harm behaviours. So, and that's particularly, again, older adolescent females. And there's a whole lot of research that myself and others are doing in trying to understand why we've seen that change. And a lot of that focuses on social media and also inequalities. But there are pluses and minuses to social media. So we're seeing, so even before COVID came along, for older adolescents in particular, and particularly young women, we were seeing an increase in all three of these issues. And then for the last decade, we were seeing a rise in rates of 10 to 24-year-olds in suicide. Now, the thing to say about suicide is that suicide in young people is relatively rare. Now, the reason I use the word relatively rare is because rates of suicide and numbers are much higher in middle-aged people, particularly middle-aged men. But middle-aged people die of lots of other things. You know, they die from die from heart disease, they die from issues to do with, you know, their respiratory, you know, COPD and things. Whereas young people don't really die of other things. So suicide is one of the leading causes of death in 10 to 19-year-olds in England and Wales. And it's really important because suicide is potentially preventable. You know, it's not inevitable. And when you combine that rise with the rise in self-harming behaviours and common mental disorders, it's why, you know, people like me were doing lots of work in this area prior to the pandemic. You know, with suicide in particular, there's very rarely a single reason. It's best understood as a complex interaction of lots of factors, some of which, you know, are from childhood. You know, it could be abuse, relationship problems, being a male makes it more common, a family history of suicidal behaviours, poverty. There's lots of reasons, and it's best understood in each individual's circumstances, but they are often very tragic preventable deaths. Now, with students, so if you look at the graph at the top, rates of suicide are much lower than in the general population. And part of the reason for that is, one, you know, the young people who experience a lot of the risk factors for suicide, which include bullying and some of the other things I mentioned, are much less likely to make it to university. And so although there was lots of media talk about high rates of suicide in the university population, it's actually much more common in young people who do not get to university. However, like I said before, in universities, we have large groups of young people where we can set about giving them the problem-solving skills and life skills to try and address some of the issues that can take them to those dark places. So when COVID came along, it raised a number of issues. So there was the pre-pandemic trends. So we were basically, you know, before March 2020, we were concerned about the mental health of young people. Educational establishments closed, and they closed before lots of other things closed. So lots of us were writing letters and advocating for young people early on in the pandemic, because there was one point when I think schools were closed, but the Newmarket races were on. And the reason that's important is that for lots of young people, university, school, these are the safe places in their lives. This is where, if they come from challenging family environments, this is where their trusted adults will be. For many young children and teenagers, you know, school, seeing their friends, it's a pivotal part of their social and emotional development. Young people were experiencing much higher levels of loneliness. Many were at an age where they were increasingly developing self-agency, you know, moving out, living on their own, or becoming more independent. And the pandemic stopped that. Many young people moved back home. One of the things that's strongly associated with suicidal behaviours is entrapment. And entrapment was, you know, that feeling of being trapped was very common during lockdown. So, and then there was inequality. So one piece of work that I'll talk about a bit later that we did early on in the pandemic basically highlighted that in those early few months, so March, April, May, young people and those in more deprived communities and parents of young children were the ones whose mental health was disproportionately impacted compared to others. So we were very worried. Now, because we were in a situation where we basically didn't know what was happening, we didn't know what the impact was going to be, the volume of research was huge, and it was a very varying quality. So one of the first things we did was set up a living systematic review. And what we've done since, well, from January 2020, but we started in April 2020. So we looked at evidence from January 2020. We have every day, some very techie people in Bristol have set up a database that searches everything published on suicidal behaviours in all ages. And then myself and other leads on the project, so David Gunnell and Julian Higgins, we have a team of people who do a lot of research and work, and we review that evidence to try and pull it together. Now, there were lots of headlines at the time, you know, lots of large surveys, but most of the surveys didn't have pre-COVID measures. So we didn't really know if things had got worse. Many of them just called out and asked people to reply. So even if you got 50,000 people replying, those people will be very different to the people who don't respond to your call to fill out a survey. And people with people with mental health issues, people whose mental health was deteriorating, are much less likely to respond to calls to fill out surveys. And many of these surveys just use self-report questions. So you don't know. So asking someone if, you know, they feel unhappy, they may be answering, their concept of unhappiness may be very different to someone else's. And that's why we tend to use validated scales. So validated scales have been tested so that the people answering them are answering the same thing. And then we didn't really know what was happening. You know, were people seeking help from services? There was a lot of talk of protect the NHS, which meant that lots of people worried about being a burden to services. Lots of the studies, they were in different age groups. So they might say they're in young people, but that could range from children under 18 to people under 40. And a really important thing about most of the evidence that I'm going to present today is that at best it's up to November 2020. So we really don't know what's happening now. And, you know, lots of the protective things like furlough have stopped. And one of the big things in children and young people's mental health is that it may not seem like it at the moment, but actually, you know, it's the Cinderella of mental health services, which is the Cinderella of health services. And research into children and young people's mental health is also much less funded than other studies. So up to about October 2020, only about 1 in 10 studies that we looked at were about children and young people's mental health. And because of all those issues with those studies, there was lots of noise. So if you struggle to really know what's going on, that's understandable because everyone has. So with suicide in particular, there was lots of alarm bells going. And some of those alarm bells were spreading things that weren't true. So this suicide figures are up by 200% since lockdown was a figure that was still doing the rounds back in June. And even we did a focus group with young people last week. And even then they were talking about how suicide rates had increased. And there was lots of, you know, that concern was really understandable we were worried about mental health services. Mental health services virtually had to transform overnight and go online. We didn't know whether people who were in crisis and distress were seeking help. There were lots of financial stresses. So although the government provided lots of financial safety nets, they weren't there for everyone. We were concerned that people in challenging home environments would be experiencing more domestic violence and alcohol consumption. There would be feelings of isolation, entrapment, loneliness. We wondered whether people would stockpile some medicines that would then be easily available in overdose. And then this media reporting that was sort of saying that suicide was increasing rapidly, what that does is for vulnerable individuals, there's a thing called the Werther effect, that when it's reported irresponsibly, particularly where the method is in the headline, it does, it gives people the psychological capability that isn't an option as a response to the pandemic. So there was lots of work going on behind the scenes to basically say, actually, we don't know, but we should be mitigating for increased rates. The other thing that happened at the beginning is both in Wales and England, there was a signal very early on in the pandemic that rates may have risen in children. Now, we're talking very small numbers here, and in actual fact, what we found from June onwards was that numbers were about the same. So the rates were never raised. Now, for those of you more statistically minded, that's because the confidence interval crosses 1. But there was a signal. So lots of us were very worried. And there was data coming out of Japan that said one of the difficulties is that you can't count, you don't count a death as a suicide until it's had a coroner's inquest, until there's been a coroner's inquest. And what that means is that knowing how many people have taken their own lives is often delayed by months. So Japan is one of the places that has real-time suicide surveillance. And from August, they were seeing suicide rates rise. And these were particularly in students and in females. So you can see the pink line in the female graph. However, Japan is very different to the UK and very different to many other nations culturally. And we now think that some of these differences in suicide rates in Japan were to do with celebrity suicides, celebrity deaths out there. So we searched the literature, and what we found was from certain countries, a number of I think it was about 9 countries at this point, actually suicide rates dropped in the first few months of the pandemic or stayed the same. So we published an editorial on that, and then an international research collaboration was pulled together to try and source data from around the world, because we really wanted to understand what was happening. So this was led by Prof. Jane Perkis, the first photo from the University of Melbourne, and myself, with Matt Spittle, David Gunnell, and the 3 in the middle are the amazing early career researchers who did most of the legwork. So Sangashu, Vikas, and Marcos. And as a result of that study, we sourced real-time suicide data from 21 countries or regions within countries up to November. And we did what we call an interrupted time series analysis. And what we saw was that around the world, suicide numbers remained largely unchanged or declined in the early months of the pandemic. so up until about November, which really was counterintuitive to a lot of the stuff we were reading in the press. There were some countries that were outliers. Puerto Rico has had, was in a very, very deep recession, so we feel was disproportionately impacted. So why did they not rise, up until November? So one of the theories we had was increased social cohesion. So people, there was more support from family, friends, neighbours, communities, and feeling isolated and alone. I'm going to close my door because my son's come home and he's not being very quiet. So there was that social cohesion and a honeymoon period if we're all in this together. There was, and that has been documented after other disasters and global pandemics. There were basically those, so suicide is really strongly associated with suicide and self-harm, with unemployment and debt. And there were lots of protective measures and welfare safety nets. There was support from services and particularly charities. So charities really stepped up and funding was given by governments to increase helpline provisions. However, within these overall rates, there were certain groups. So there was a study from Detroit that showed that rates had risen in people from ethnic minority communities. So I think what's really important to remember is behind these overall figures, there could be trends that we need to be worried about and populations that we really need to support. And then I think the other really important thing to highlight is that none of the countries that we could get data from were low income countries. So we largely do not know what is happening in low income countries. We're doing what we can to work with those countries. So many of you may have heard, I myself did, from people working on the ground, so paramedics, people in emergency departments, and the police, that they were seeing lots more presentations for self-harm and distress. Now, when we looked at the data of how many people were going to services, so that was primary care, emergency departments, and being admitted. So we've done that study in Wales, but this is a study that looked across 10 countries. Emergency department presentations for mental health related issues fell in those early months of the pandemic. Now, presentations for everything, heart disease, everything fell. However, while presentations for self-harm fell, their proportion was higher than before. So whereas before about 50% of young people presenting with for mental health to emergency departments, it was about 50% of it was for self-harm. In 2020, it increased 57%. And that's why we think that maybe people on the ground had the impression that it was increasing. There was no difference in those presenting with severe self-harm. And there was no indication that young people from deprived areas or ethnic minorities were disproportionately affected. And that will, the reason that's important will become evident when I talk about another study. And the same thing was found in primary care data. So if you look at these lines, there was a fall across all age groups in presentation for self-harm. And we've done this study in Welsh data, and it's the same. But the biggest drop is in that pink reddish line. So the biggest drop we saw was in young people. And there was limited recovery by July last year. And what the concern is there is that there was lots of unmet need. Now, the acute crisis for those young people may have passed, but many of the reasons, so when someone presents in distress or self-harming or with suicidal thoughts, one of the things we do with them is called a comprehensive psychosocial assessment. And what that means is you have a conversation about the issues in that person's life that have brought them to that place. And then you set in motion the things that might address those things. And you also do what we call a safety plan with people, where you work with people about what do they do when they next feel like that. And for some people, it's I'll ring my mum or I'll ring the Samaritans. With other people, it's I'll listen to this playlist. And you'll work through with them. What do you do if that person's not in? What do you do if you can't get through to that helpline? Now, none of those things will have happened, for any of these people. And I think going forward, if we ever have to go into a stay-at-home order again, maintaining access needs to remain a key priority. So what about the mental health of children and young people? So there's lots of stuff out there. In the early phases of the pandemic, the first couple of months, that first study that I will talk about again in a minute, young people were one of the groups we were particularly concerned about. They're also the group, older young people transitioning from school, college or university into employment. It's the sectors that they work in, like hospitality, that have been most affected by the pandemic. So there are concerns about their prospects. But this study, the mental health of children and young people in England, is another probability sampled survey. So they're not doing what we call convenient sampling. They're just putting some stuff out on social media, asking whoever's interested to reply. This is a properly constructed sample. And in this study, they found that probable mental health conditions in 5 to 16-year-olds across all ages, sexes and ethnic groups had increased by 5%, by around 5%. Now, that increase at a population level is quite large. So we're talking about all 5 to 16-year-olds. And one of the things that came across in that survey is that the young people who had probable mental health conditions were more likely to have heard arguments, were more likely to report that they were experiencing financial adversity, and more likely to have problems with their sleep. Now, another study, and the thing about a lot of studies that are based on under 16-year-olds is that it's usually parents reporting. So it's not the young person saying what's going on. So CoSpace is a study of 2,500 parents and carers of children and young people. And what's good about this study is that we've got 2 time points with the same families. So if you think back to that thing of like, if you're asking lots of different people all the time, you can't really compare it. With this, you can see what happened to the same people over time. And what this study's found is that for under 11-year-olds, there was about a 10% increase in possible and probable emotional symptoms, a 20% increase in hyperactivity, and a 35% increase in conduct problems. Now, this is for very young children who were locked down and school closures are very likely to have impacted on, who they were seeing, their social, at that time of rapid social and emotional development. However, for adolescents, while there were increases seen in inattention and conduct problems, overall emotional symptoms reduced. Now, this is still a self-selecting sample, but it's really important as we go forward to remember that for some children and young people, school and friends are actually very stressful. There's the academic pressures of school, there's all the problems with bullying and exclusion and feeling all the issues with your peers. So for some young people, being at home was better. And for other young people in challenging home environments, it would have been worse. And while there were big differences based on ethnicity or deprivation, those in low-income households had higher counts. So one of the things that's come across both in the way COVID has worked and in the way the mental health impact has worked is it's disproportionate. So if you remember that analogy right from the beginning of the pandemic, we're all in the same storm, but we're not in the same boat. And for people with pre-existing mental health problems, for people from deprived communities, and for those from ethnic minority communities, the experience looks like it was very, very different. So this is one of the last studies I'm going to talk about. So research-wise, this is about as exciting as it gets in academia. This is a survey, it's called Understanding Society, it's done in repeated waves. It was going to be one of the first set of results where we would have data, we would know about people's mental health prior to the pandemic. And so we raced to get this out. And the reason we raced to get this out, and it's the same reason why so many of us have worked advising government this year, is because the situation was so rapidly evolving and was so uncertain. You needed to get the evidence out there so that policymakers, service providers and advocates could be asking for the things that were needed. So I talked about that very first study, which was up to April last year, where we found that it was particularly parents of young children, people from deprived communities, young people and those from deprived areas, where what we call it is mental health, but it's not always diagnosable, the questionnaire that we use here. But there was a shock initially. And that's that sort of high level that you see near the 13 in the top graph. Now, by July, that score dropped, which means that people's mental health was recovering a bit. But that dotted line is what the population's average mental health was before the pandemic. And by October, we still hadn't, as a population, returned to normal. So what we then did was look by age group. And that's the lower graph. And what you see is that for males and females, they had, young people, their mental health had recovered. So that there has been some recovery, and I think that's really important to understand. And so this second paper at the bottom was only published a week ago. And what we did, right, if you're not academically inclined, this is going to look like a really messy graph, so I'll do my best to explain that. So what we did was we used what's called latent class analysis to identify trajectories of mental health. And we found 6 trajectories. 5 trajectories. So basically, at the bottom, so the higher your mean GHQ-12 score, the poorer your mental health. So the first 2 lines at the bottom shows about shows people whose mental health stayed pretty much the same across the last year. And then the light green line shows people whose mental health deteriorated early on in the pandemic, when we looked at it in April in that first paper. But then that downward slope is showing that they recovered. So 3/4 of the population, 3/4 of the population had consistently good or very good mental health throughout. Predominantly in that group were white, older people who were financially better off. A lot of the population mental health recovered, but the top 2 lines, so the red line and the green line, are the people in our society that we really need to be concerned for and doing something about. So basically the red line shows those whose mental health stayed consistently poor. It stayed up as a high score. And the green line shows those in our population whose mental health was deteriorating throughout the pandemic up to September. And what that says, in those groups are people from deprived communities, people from ethnic minorities, and people with pre-existing mental health and physical health problems. And, I personally feel we really need to be thinking about the broader determinants of mental health when we do something going forward. Now, this is my last slide. I can see Liz has come on, which was my 5-minute warning, which I always need. So I think the last things I want to highlight is, we're all still working a bit blind. The data I'm talking about is up to last November. We still, we don't know. So there's lots of surveys out there, but if we're talking about robust research, we don't really know what happened in the second lockdown. Suicide rate, it looks like suicide rates did not increase last year. However, we're going forward into a recession and levels of unemployment are rising. So I do think we should be vigilant, concerned, and acting to mitigate these things. People's mental health at a population level is not at pre-pandemic levels. However, it's not the, the catastrophizing discourse that we hear often in the newspapers. We really need to focus on those populations where there are issues. It does look like there was an increase in suicidal thoughts and mental distress. But actually, often those are relatively common responses to difficult and uncertain situations, and they do not necessarily translate into behaviours. We've talked about disproportionate impacts. I think we really need to think about wider determinants, financial safety nets, services, addressing domestic violence, safeguarding, to interrupt those trajectories for young people. And, we hear a lot of talk at the moment about back to normal. I don't think we should go back to normal. There are all those groups that have had a disproportionate impact on their mental health in over the last year were the young people that we were worrying about before. And a new normal is better. It's very much been politicised, but I'm firmly behind let's build back better.
Thank
So
you,
that's all I
Anne.
was going to say.
That was a really, good finale. Thank you. So I forgot to mention at the beginning of the webinar that during this week, Mental Health Awareness Week, we'll be giving people the opportunity to support this crucial research into adolescent and young people's mental health that we undertake at the university, of which Anne is a leading figure. So there's going to be a little link coming up in the chat in a second. So please feel to contribute. Thank you. And we've just got a couple of questions, Anne. So the first two are around specific areas of research. So one asking about the impact, is there any research about the impact of alcohol on the suicidal behaviours of teenagers?
So we've done some research in that area, but there is quite a big body of research, and basically it has an impact on lots of different levels. So there's the acute impact. So when people are distressed and they drink, alcohol is a depressant. It also lowers your inhibitions. So the acute event is very associated with alcohol. However, chronic alcohol abuse, which does happen in young people, is highly associated with suicidal behaviours. And then I guess the final level to highlight is young people growing up in households where there's a lot of alcohol abuse. That's considered an adverse childhood experience, which is an increased risk for suicidal behaviours. So there is a lot of research. I think there could be more. However, what I would say with alcohol is that we know that things like brief interventions work. And so it really is about being able to deliver those. And one of the things we do with some of our health professional students is teach them how to deliver those brief alcohol interventions. Because, you know, the people who work in alcohol services will do it. But actually, it's the people who will come across young people with these issues in the other walks of life that should be able to deliver, because they're really quick interventions, 2-minute interventions, who should be the ones who can just bring that in to a contact with a young person.
Thank you. So we do have a few questions now. So I'm just going to pick a couple out, and we'll see if we can get through them all. If we don't, then we'll pull some of the questions out and forward to Anne. And if Anne does have time to respond, I'm sure she will. But in the meantime, so this is quite an interesting one here, Anne, about Zimbabwe. So in Zimbabwe, there was a high rate of severe domestic violence, some were even fatal. Could that be a sign there were suppressed mental health issues that the COVID-19 lockdown exposed or triggered?
So there is evidence out there that domestic violence increased across, you know, all nations. And if you think about it, you can see why people were in households together. You know, for lots of families, there's the respite of people going to work and being able to go to school. I would say with most harassment and bullying, both victim and perpetrator have mental health problems. Now, that is not me saying that people do not have to take responsibility for their actions, particularly their criminal actions, but usually everyone involved needs support.
Thank you. Okay. It's a very big question here, which is quite a task. So I've witnessed people asking for mental health help but not getting an appointment until weeks down the line. Why do we need to have a referral from the GP before we access mental health help? Why can we not just walk into a clinic or have access to an online chat right at that moment? Oh, I've lost the question now. Where's it gone? Sorry, it went out into the different list. And why, yeah, without having to go to regular A&E and being embarrassed, how do we push a whole new reform of the system?
So that very much ties in to the fact that, you know, mental health services have been chronically underfunded. But equally, mental health services are not always the appropriate places for people to go. So, you know, often referrals from general practice often act as a sort of gatekeeping stopgap to stop a service getting overwhelmed. I think where there's some positive things to say is there are pilots going on around the country and in Swansea that are about having, when people are in crisis, instead of being taken to A&E, they go to, it's like a sanctuary where they'll get help. So there are, and then I think, you know, the provision from the third sector, the crisis lines and the web chat supports that they provide, particularly for young people, well, for all age groups, but I know a lot more about the ones for young people, are really, really good. And I think one of the things, we're doing some work with an organisation called craith, and they provide mental health support to young people in lots of different levels. So it can be peer-to-peer, there can be a counsellor involved, it could be a web chat, information. 20% of the young people who access their services are from ethnic minority populations. I do not see that in any other setting that I work in. You know, that these are young people who are quite marginalised. And so for some people, you know, I think in your question you alluded to feeling ashamed. I think for some people, the provision of online and web chat support is really important. It won't, what I tend to say is people want to chop and change. So young people, sometimes they want to see someone face to face, sometimes they want a web chat, sometimes they want a phone call. And we need to be able to be responsive enough that they can do that.
Thank you, Anne. Well, I'm afraid we've run out of time for the rest of the questions. However, we will save them. So thank you, everybody. We've got time for one last question. Okay, if you're okay for one last question, Anne. So there's one here that says really interesting work going on by your teams. Is there opportunity to advise educational settings on the support our young people should be getting to reflect on the past year, please? And that links to another question asking, should teachers in schools and FE colleges have better training or training in regard to how to deal with what's come in, basically?
So a couple of things I'd say about that. So in Wales, Welsh Government and TAG, which is the advisory group about COVID to government, they have a subgroup on children in schools. I sit on that, but so do lots of other knowledgeable researchers in this area. And I think, you know, we are constantly feeding in the research that we do and the things that we find. So, you know, we've recently done a study looking at absence and exclusion prior to the pandemic and the link with diagnosable mental health disorders. And we fed that directly into Welsh Government. So yes, it does happen. I think with teachers, it's one of those things. We want teachers to be able to respond in a calm, non-judgmental, non-stigmatizing way to young people in distress or who want to talk. And sometimes, you know, that particularly in self-harm, there's lots of young people I've spoken to where the response, you know, both from health, education, friends, has been less than compassionate. And I think there's something about sometimes that's because people don't feel safe having those conversations. So there's definitely something about ensuring that people feel comfortable having those conversations, because they're normally, you know, very private things that young people are talking about. And so when they do open up, you need to be able to respond. Otherwise you can do a lot of damage about future help seeking. However, teachers, you know, there should be a named person in a school that they can refer to. They don't have to become mental health professionals. You know, there needs to be better integration with child and adolescent mental health services so they can ask advice. And, you know, in Wales, we have Together for Children and Young People, which is the strategy for mental health in young people. And there's lots of work going on about mental health literacy in schools, about integrating those services, about making those things happen. So yes, absolutely, they should, but they don't need to become mental health professionals.
Great, thank you, Anne. And thank you to those of you who've asked questions, and apologies if we didn't get around to yours, but we will save them and do our very best to answer them. So that just leaves me to say a huge thank you to Anne for such a comprehensive and interesting talk. I'm sure everybody's really enjoyed it, and I wish you all a very good Mental Health Awareness Week, the rest of it, and I hope you can join us for some of the other events as well. So thank you, everyone.
And thanks, Liz.
Thank you, Anne.